And our keynote speaker was going to be Dr. Kelly Posner Gerstenhaber, who works for Columbia University, and she created the Columbia Suicide Severity Rating Scale. And if you're on the MVPN mailing list, you know I've been picking at you about this all year. And you're going to hear more about it. I don't want to steal the presenter's thunder, but I will apologize. We do not have Dr. Posner today. And there's a very good reason for that, and because she is at the White House today, and so our keynote speaker was stolen by the president. And the CSSRS is of quality and accuracy and of a research standard that it seems to be applicable to some of the shootings that we've seen lately, like in Parkland, Florida. So she's there as part of the task force, and we've had to share her. But she sent her deputy. When she called me, she said, I have good news and good news. The good news is that the White House is interested in the CSSRS as a way to prevent some of these shootings. And the good news is that we get Mr. Adam Wessler, who's going to deliver a quality presentation and tell us all about what they're doing at Columbia. He's a licensed clinical social worker. He's the assistant professor of clinical psychiatric social work in the Division of Child and Adolescent Psychiatry at Columbia University, the Galos College of Physicians and Surgeons, and a deputy director of Columbia Lighthouse Project and New York State Psychiatric Institute. There he's responsible for all the suicide prevention activities related to public health. Of note, numerous states, countries, and branches of the military have moved towards the system-wide implementation of the methods he worked on. He's published, presented internationally, and consulted the state and local governments on best practices for suicide risk identification and prevention. And he's been featured in Social Work Today magazine and on Atlanta National Public Radio, CNN, Espanol, Univision, and other local and print television media outlets. Please give a warm welcome to Mr. Adam Wessler.
Thank you very much, Harry. Good morning, everybody. I'm sorry that I'm not as attractive as the speaker that you were expecting. She does wish that she could have been here, and would have been here, had it not been for some very important people you heard about demanding some of her attention. So I'm going to talk with you this morning about the Columbia Suicide Severity Rating Scale. Talk to you a little bit about the issue of suicide, how the Columbia was developed, how it's being used in across our nation, and how you can use it to assess risk of the veterans that you serve. I will leave a copy of the presentation with Perry, and so he can send you my slides. I hope that he will, so that you'll have your own set and don't have to write down as much information, because I did not get the email about 3 words per slide. And my emails are, my slides will be pretty dense. Before I begin though, I always talk to my audiences about the personal impact that suicide has on most of us. Many of us in here may be survivors of the loss of a client or a friend or a family member. And some of you may be survivors of your own suicide attempts, and so I urge you to pay attention to how this material makes you feel and do something nice for yourself at the end of the day. Take good care of yourself, because we don't take enough care of the caretakers that we really should. The other thing is that I don't want you to take what you learned today and feel bad about something that may have gone wrong in the past. You couldn't do anything differently than what you did in the past, and we're going to take what you learned today and we're going to use it to move forward and to make a difference. So we know suicide is a global public health crisis. Nearly 1 million people die from suicide across the world every year. It's responsible for more deaths than natural disasters, war, and homicide combined. And it kills more people in our country than car crashes. Yet we see all kinds of public service efforts at preventing car crashes, right? The drunk driving checkpoints, the seatbelt checkpoints, don't text and drive campaigns. We don't see that aimed at suicide because of the stigma that's still attached to suicide and most mental health issues. And the tragic paradox of the military is that they have more suicide deaths than combat deaths. 20 veterans every day and 1 active duty soldier. And we know that suicide touches just about everyone. We expect that it will touch about 135 people for every 1 death. So it's really hard to escape from being impacted by suicide. You know, it's actually the #1 killer of teenage girls across the world. And it's the 2nd leading cause of death now in our country among teenagers 13 to 17 and young adults 20 to 36. But deaths from suicide is really just the tip of the iceberg. So we lost about 43,000 adults to suicide in the United States in 2015. But for those 43,000 deaths, there were 1.5 million suicide attempts, about 25 for every death. And about 10 million American adults seriously considered it. So finding those folks who are thinking about it, who may go on to make an attempt, is quite a challenge. And that's where the CSSRS is making a difference. And you know, it's not just in our mental health centers that we need to look for people who might be suicidal. You can be suicidal and you will be more likely to be suicidal no matter what medical illness you might have. So one study looked at cancer patients and found 18% had suicidal thoughts, irregardless of any depression that they had. And for other illnesses, stroke, heart disease, epilepsy, arthritis, chronic pain, all of those illnesses increase your risk for suicidal thoughts and behaviors. So we need to look in our primary care doctors' offices and in our nurses' offices and not just leave it up to our social workers and behavioral health specialists. And it's a crisis in every sector that we look at. You know, it's the #1 cause of death in our jails in our country. And it's often the #1 cause of death among first responders themselves. We lost more firefighters to suicide in 2014 than we did in fires. And first responders, we train them often how to ask these questions. We do a lot of CIT training for police officers. And they tell us, you know, thank you for giving us these questions because we not only can use them in our communities, but we can also ask them to our partners and look at them ourselves and decide whether or not we need to get some help. And this is new information, but not very surprising. It turns out that a great majority of the opioid overdoses that we see are actually suicides. And that makes a whole lot of sense when you think about the opioid crisis. Many of it results from people who are medicating chronic pain, and we know chronic pain increases risk for suicide. And also people get into drug abuse when they're trying to medicate their depression and their anxiety and other mental illnesses. And alarmingly, because of both the opioid crisis and suicide, we now are the only developed nation in the world who for the last 2 years has seen our average lifespan decline. Every other developed nation in the world is seeing that inch up, but our country has seen it go down because of all the people in their middle ages who are dying from suicide and opioids. Now, while the greatest numbers of suicides are happening in our cities, the greatest rates of suicides happen in the rural parts of our country. And there are a number of reasons for that. The first being that they tend to have populations that are spread out across a great distance and they don't have good access often to mental health care or medical care. Before I came to help direct the Lighthouse Project, I was the Youth Suicide Prevention Director in the state of Georgia. And we would see just this problem that when families in the rural parts of the state were out of work and they couldn't afford to make ends meet and they were struggling, they didn't take their kids 45 minutes or go for themselves 45 minutes to a mental health appointment, right? It becomes a low priority when you're struggling. The other thing about the rural parts of our nation is that if you track all of the demographic statistics up against rates of suicide, the one demographic statistic that most closely tracks with rates of suicide is not socioeconomic status, it's not level of education, it's rates of gun ownership. And so these maps look at the counties in the United States with the highest rates of suicide and the states in the United States with the highest rates of gun ownership. And you can see the states where there are low rates of ownership in California, New York, New Jersey, Illinois. They're also states that have the lowest rates of suicide. And this collection of data makes that point very dramatically. This is a look at the taking a grouping of the states with the highest rates of ownership of guns, comparing them to the states with the lowest rates of ownership. And that gives guns in about 56% of the households in the high rates of ownership states, and about 20% of the households in the low rates of ownership states. And when we compare them, we see that the numbers of non-firearm suicides are roughly the same. About 8,200 men and 8,700 men, and about 3,500 women. But the numbers of firearm suicides are 4 times as great for the men in the states where you have a lot of guns, 16,000 compared to 4,000, and almost 10 times as great for women. Only 300 in the states with low rates of gun ownership compared to 3,000. And what's going on here in Texas when it comes to veterans and suicide? In 2014, you lost 554 veterans to suicide out of the 3,254 suicide deaths in your state. And that was 17% of your suicide deaths. 71% of those deaths were by firearm, compared to 55% of the overall suicides. And when you look at the ages of your veterans that are dying by suicide, it's a pretty even spread. 18 to 34-year-olds were 112 of them, 35 to 54-year-olds were 161 of them, 55 to 74-year-olds were 182 of them, and 99 were over the age of 75. So quite a spread across the lifespan for your veterans that are dying by suicide. And we need to talk about depression, because depression is on its way to becoming the most debilitating disease we have in the world. It's already the most debilitating disease in our country. It's responsible for more work-related absence than any other illness that we know of. And that actually costs our economy $23 billion a year in people who call out of work sick for depression. So it not just impacts individuals and families, it actually also impacts our economy in very dramatic ways. Now, while we know that most people who have mental health issues are not suicidal, 90% of people who do die from suicide have a mental health issue at the time that they die. And 60% of that is depression. The unfortunate thing, though, is that we know that even after all of our hard work, most people with mental health issues aren't getting the help that they need. We know that it's about 50 to 75% of adults and about 70% of children and teens who have depression don't get any kind of care. And 80% of teenagers and college students who die from suicide were not ever getting any kind of treatment prior to their deaths. So we're not identifying who needs help, and we're not getting them the help that they need. So we know that we need to screen to find these people. One of the early studies that we did took a look at the centrist military health records in a retrospective chart review. We looked at about 1,500 cases that were admitted to Walter Reed between 2001 and 2006. 11% were admitted for serious suicidal ideation, and 12% with an attempt, and they had no documentation of any past behaviors. No suicide screening was done, and no assessment measure was administered in a single case. And we know that 45% of people who die by suicide see their primary care doctor in the month before they die. And for adolescents, many will go to the emergency department for an injury or an illness and are not there for a psychiatric reason, but have a history of suicidal behaviors or ideation, and they're not asked these questions. And we know that if we ask, we will find these folks. We know that screening programs work. High school screening programs have been demonstrated to effectively find people who are suicidal. College screening programs have been shown to decrease the numbers of suicides on college campuses. And elderly primary care screenings show a tremendous benefit in finding elderly folks who also are depressed. And we've seen lots of examples now about how just screening in the military is making a difference. The Navy Chief of Chaplain's Office screened all Coast Guard cadets a year or two ago anonymously and communicated the results to leadership, and as a result, they were given extra funding to conduct suicide prevention training, and that training resulted in several cadets coming forward and saying that they needed help. And why aren't people getting help? One of the great reasons that people aren't getting help is the stigma that's attached to the issue of suicide. And this is a quote from a sergeant major, an 18-year veteran, who says, "We obviously have a peer-to-peer stigma. The machismo that I can't admit that I see a counselor or a psychiatrist. That makes me weak. And we're at war and there can't be any chinks in the armor. And we know that there's a gender difference too in treatment seeking. So we know that that women attempt suicide twice as often as men do, but men die by suicide 4 times as frequently. And there are a couple reasons for that. The first being that men tend to choose a method for suicide that's much more lethal the first time they try. They tend to choose firearms or hanging, and women tend to choose overdoses with medication. The other thing, though, is that there's much less of a stigma for women to go out and ask for help than there is for men. So when autopsy studies were done in New York City on suicide deaths, they found that about 40% of the women had antidepressants in their bloodstreams and only 11% of the men did. So the women were actively out looking for help, the men weren't. And we know that there are gender barriers for veterans as well. So male veteran suicides, we know, have about 5 times the rate of non-veterans and increased about 30% over the past decade, I believe. But female veterans are 12 times the rate of non-veterans and have increased 80%. So we know that female veterans in that age group of 18 to 29, our younger veterans, are increasingly at risk. And this stigma can be lethal. We work closely with Kim Ruoko. Kim Ruoko is the communications director at TAPS, which is a program that assists families after there's been a suicide in the military. And she lost her husband, who was an Air Force pilot, to suicide. A Marine pilot. And his buddy said to him, whatever you do, don't go to mental health. Don't go on medication, because if you go on medication, then you can't fly, and you're too good for us to lose. And luckily, since that time, we do have medications now that you are allowed to take and fly on, psychotropic medications. So we're moving towards a better way to let people ask for help. And reducing stigma is saving lives in the Army. So in the Army, they've now instituted this behavioral health data portal. And this behavioral health data portal allows for people to take the CSSRS screening at all of their medical appointments. So they do this in the dentist's offices, they do this in their primary care offices, and for that reason, you don't have to go to the stigmatizing building that says mental health, right? And you don't have to be seen walking into that building. You get it in where you get all the rest of your care. And as a result, they've reduced their inpatient overnights by 41%, saving $30 million in the last 5 years. And have also seen a decrease in suicides. And we know that people want to be asked these questions. 95% of people who are suicidal are ambivalent about it. It's one of those symptoms that comes and goes with your level of stress. And if you help somebody through that high peak crisis time, they may never get that suicidal again. You may make a tremendous difference in their life. And we do a lot of co-training with this man named Kevin Hines. Kevin Hines is a survivor of his own suicide attempt by jumping off the Golden Gate Bridge, which is lethal 99% of the time. He's one of only 5 people to survive that jump and can still walk afterwards. He's a very dynamic speaker, and he tells his story. He was a 19-year-old young man with a psychotic depression, and he said to himself that day that he jumped, if just one person asks me what's going on, I'll tell them everything. I'll tell them my whole story, and I'll get help. And he is crying all the way on the bus to the Golden Gate Bridge. People are moving their seats because they don't want to sit next to this kid who's crying. He gets to the bridge. The bus driver says, "Come on, kid, get off. I've got places to go." He's walking up and down the bridge 2 or 3 times crying. Nobody says a word to him. Finally, somebody is approaching him. And he thinks, oh my God, somebody is going to ask me, thank God. And she asks him, will you take my picture? And at that point, he decides nothing matters, nobody cares, and he jumps. And he says he realized at that moment that everything in his life that he thought was unfixable was fixable except for what he had just done. And he says most people considering suicide want somebody to help them. And what we need is a culture where it's okay to ask these questions and talk about it. Now, interestingly, he hits the water and he realizes he's still alive, and he's down about 40 feet below the surface. And he starts to feel something slimy swimming around him. And he thinks to himself, oh my God, I just survived this jump and I'm going to get eaten by a shark. And it wasn't until about a month later that he was on a television program, a talk show, and somebody called in and said, you know, I saw you jump that day. I'm so glad that you're alive. And by the way, that wasn't a shark, that was a sea lion, and it circled under you, keeping you afloat till the Coast Guard arrived. Yeah. So whether you believe in divine intervention or that animals can sense what we need, it's a very powerful story. And because we know people want help and want to be asked, we're working now with the firearm community to make sure that they know these questions, they know who might be at risk. You know, Dr. Posner was on CNN this morning because we are now talking about the fact that almost 80% of school shooters have a documented history of suicidal thoughts or behaviors. And screening in our high schools for suicide may actually find those folks who might go on to be shooters. And that's why she's being invited to the White House and why she was on CNN this morning. But we know that 2 out of every 3 gun deaths are suicides. Most of our deaths by guns are suicides. And so we have a poster with the CSSRS questions that we provide to gun shop owners and to firing range owners so that they can post them and they can ask the questions if they feel that, you know, somebody coming in doesn't quite look like, you know, like they want to sell them a gun. They want to check their mental health status. So we know that suicide is preventable, right? We can prevent it by making sure people who are suicidal don't have access to these lethal means, and we can prevent it by giving them treatment with psychotherapy and psychopharmacology. But first we need to identify them. And the problem in our field for many, many years was that we didn't have a common language for how to talk about suicide. So we would see the same exact behavior and it would be called 16 different things by 16 different people. Right? It would be called suicide threat, suicide gesture, non-serious suicide, and we couldn't assess risk when we were using these different terms. And so we also couldn't compare one community to another community. So our epidemiology was actually problematic when we didn't have a common language. But now, thanks to the CSSRS, we do have this common language. The CSSRS was developed about a decade ago as part of the first National Institute of Mental Health study looking at suicide attempt survivors, teenage suicide attempt survivors who were coming out of the emergency department and what was going to be helpful for them. And these top researchers at Columbia and at University of Pennsylvania and University of Pittsburgh put the questions of the CSSRS together so that you would have all the scientifically based, evidence-based questions you would need to ask somebody to figure out if they were at imminent risk. And so since that time, it's been used tens of millions of times in millions of settings. It's considered the most evidenced risk assessment tool out there. It has excellent acceptance. It's good for all ages. It's been used for kids as young as 4 and 5 and adults upon over age 100. And it's just a few very simple questions. This is the short 6-question screener version, which is the version that we give out to anybody in the community who wants to learn how to ask these questions. And those 6 questions begin with, have you wished you were dead or wished you could go to sleep and not wake up? And have you actually had any thoughts of killing yourself? If that second question is no, that they haven't had any thoughts of killing themselves, you get to skip 3, 4, and 5, and you move on to 6. But if question 2 is yes, you ask 3, 4, and 5. 3 is, have you thought about how you would do it? So have you thought about a method? Question 4 is, do you have some intent to act on those thoughts? And question 5 is, do you have a plan and intent to act? Right? You can't have a method or intent or a plan if you've never had a thought, so you skip 3, 4, and 5 if 2 is no. And then you ask about behaviors. And the behavior question says, have you ever done anything, started to do anything, or prepared to do anything to end your life? And it gives examples of all of those types of behaviors. And I'm going to explain those behaviors in a second. But because the CSSRS is so science-based, it actually protects against liability issues. So people say to me, or used to say to me often, if we start screening everybody who comes into our clinic or everybody who's in our schools, aren't we going to open ourselves up to liability if something bad happens? And the truth of the matter is that people do not get sued when bad things happen. People get sued for negligence, for not doing something. And all of the lawsuits that I've seen about suicide in schools are successful when someone knew something and didn't say anything, right? They're never successful when somebody assessed with a proper tool, documented their answers, and got them some help or made a referral. And we now have about 100 studies supporting the CSSRS across different cultures, different properties and subpopulations, and close to 1,000 published studies in the last 5 years alone. And so the CSSRS definitions have now been adopted by the Centers for Disease Control and the Department of Defense, and are the recommended definitions that people should use when it comes to suicide. Now, they also have in the CDC document for researchers a list of the words to stop using. Things like suicide threat, suicide gesture, non-serious suicide. Things that we used to say and have a judgment attached to them. But also things like completed suicide and successful suicide, right? You complete a project and you're successful at your job, and we want to take those positive words away from something like suicide. And so the recommended language now is to just say died from suicide or attempted suicide. It's very hard to move a culture away from something that they're so used to doing. So we still see a lot of completed suicide written in our media, and some of us even slip up and use it sometimes, but we're really trying to move away from that. So the 4 behaviors that are so important that the CSSRS is the first tool to take a look at begin with an actual suicide attempt. And an actual suicide attempt is a self-injurious act undertaken with at least some intent to die as a result of the act. And there are 3 important parts in our definition. The first is that it says self-injurious act. It doesn't say self-injury. There doesn't have to be any injury for it to be a suicide attempt, just the potential for injury. So if somebody puts a gun to their head and pulls the trigger and the gun fails to fire because it's jammed or broken, as soon as they pull that trigger, that becomes a suicide attempt. The second thing is that it says at least some intent to die as a result of the act, with the important word there being some. As long as their intent to die is non-zero, it's a suicide attempt. Now, often people have mixed motivations when they make suicide attempts. And sometimes people will do it because they want to make someone jealous or make someone angry. But as long as a little part of them wants to die when they do it, it's a suicide attempt. And then finally it says as a result of the act, meaning that they have to engage in that behavior because that behavior is going to kill them. They have to be connected in some way. Now, it used to be when I graduated from social work school, that's the only behavior we asked people about. We only asked them, have you ever tried to kill yourself before? But there are 3 other behaviors that are just as important. And the first one is an interrupted attempt. That's when someone starts to take steps to end their life, but someone or something stops them. That's somebody who picks up a gun and it gets wrestled away from them, or they're on a ledge and the police officer pulls them back in. If you ask those folks, did you ever make a suicide attempt before? They'll say no, because they didn't actually do anything. They were stopped. The third behavior is an aborted attempt, or a self-interrupted attempt. That's when someone starts to take steps to end their life, but they stop themselves, they change their mind. And all of these definitions are on our website, they're on the forms themselves. You can download this and it's all free for you to have. An aborted attempt is when they change their mind and stop themselves. So that's somebody who's planning to drive their car off a cliff and halfway there they turn around and come back home. Or they pick up a gun and they're thinking about using it and they put the gun back down. We heard an example of the importance of this behavior when we were training in a Detroit hospital. And they told us about their most recent suicide attempt. A man had driven his car at high speed into a wall. And they asked him this question, and he said, you know, there were 4 other times that I drove really quickly toward that wall, but I stopped before I got there. And no one's ever asked me a question like that before. So now imagine if a week before he had been at his primary care doctor for his annual physical, and the doctor had asked this question. Maybe they would have found him before he actually had that injury. And then the final behavior are preparatory behaviors. That's any behavior that has suicidal intent other than verbalization. So things like acquiring a method, looking up ways to kill yourself on the internet, giving away your valuables, or writing a suicide note. Things that get someone ready for making an attempt. The importance of this behavior actually came when we were training a VA hospital recently. And they told us about their most recent veteran who died from suicide. He was in his 70s. He had been in to see his psychiatrist. He had been asked their usual questions, denied them. Upon his death, though, from suicide, they found that he had been putting clothing in different bags and labeling them for charities and stockpiling food for his pet for 6 months, making these preparations. And to that system, knowing that they didn't know this was an important question to ask really mattered and made it very important for them to learn this. Now, why are these questions different? These questions are different because this is a look at 32,000 assessments with the CSSRS. And when we looked at 32,000 assessments of depressed study subjects, we found that only 13% were those actual attempts, and 87% were the other three behaviors. So if all you ask about is, have you ever tried to kill yourself, you're going to miss the majority of people who have done these worrisome things. And we've really come to believe in our center that everyone everywhere can and needs to learn how to ask these questions. So when we train in a school, we like to train all the teachers in the school. We like to train all the coaches in the school. We just got back from training the Princeton University coaches and the dorm advisors. We like to train even the bus drivers, because you never know who's going to be in a position to notice someone who doesn't look so well and can ask them these questions. Now, we're not training them to be mental health providers, but we are giving them the few questions that they might need if they were in a situation where they felt they might need them. And so in hospitals, we train janitors and receptionists. We were talking to the state of Connecticut recently, and their big hospital system there told us, yeah, every staff gets trained how to do it, even our janitors. And the VA person there said, absolutely right. I'll never forget the guy who was in the hospital here. The only person he ever spoke to was the janitor. And again, that doesn't mean that they have to use it, but if they need it, we want them to be able to have it. Now, we're actually undertaking a tremendous project right now at the direction of Secretary Shulkin to train every VA employee, from the cemetery workers to the canteen workers. They're all going to take a break from their positions for 30 minutes and get a training from Dr. Posner on how to ask these questions. Very exciting. Thank you. And it all comes from the Marines, which decided early on that we need to go beyond the medical model. You can't leave this just in the hands of social workers and doctors. And the reason that they did that was because when they asked us to come in and train folks, they didn't ask us to train the behavioral health staff. They asked us to train the financial counselors and the chaplains and the support workers and the lawyers, because actually the most common precipitating event before a Marine suicide is having a legal problem. They get arrested for a DUI or a domestic violence charge, and they're attempting suicide because of the impact that has. So when the Marines now, every time a JAG lawyer meets with a Marine, the lawyer asks the screener questions and takes them to behavioral health if they feel that they have a high risk. And so we've developed these ACE cards, which stands for Ask, Care, and Escort, for all of the military men and women, with different branches of the military on the front. And on the back, they have the short 6-question screener. And the highlighted red answers are the high-risk answers, and it tells them, if these 3 answers are yes, you should take someone immediately to behavioral health and get some help. So this started in the Air Force, so now it's in every airman's pocket and the pockets of their spouses. And we're moving on to a lot of the other branches as well. And when we stick to just a medical model, which is a narrow approach where mental health is the only folks who do this, the majority of our servicemen and their families won't be affected. But when we take a public health approach and we provide this broadly and target the whole community by training all of the gatekeepers, that's when we can really make an impact and a difference. And so the Air Force is approaching this zero suicide model by training security and safety patrols, by training behavioral health as well as the family service workers, their primary care providers, their spouses, and all of their support workers. And Fort Carson was the first Army base we worked with, and they provided training both on post and off post for all of their community behavioral health and hospitals, as well as their on-base behavioral health and hospital workers. And so, since embracing this everyone, everywhere approach, Utah was the first state to do that. And they brought in together all of their public health people. They brought in their from human trafficking advocates to domestic violence assault interviewers to all of their police and firefighters and all of their school teachers. And when they did that in 2014, they saw the first reduction in suicides over the past decade because of this everyone, everywhere approach. And Centerstone is the first community behavioral health program to embrace this everyone, everywhere. They ask these questions to every person who comes in for care at every service delivery point. So if you're in to see a psychiatrist for meds, and then you're seeing your social worker for case management, and then you're in a group, you could ask 3 times in that day. And they just make it part of their normal vocabulary. We talk about this all the time because this is so important that we keep everybody safe. And if they score high, they place them into a suicide-safe pathway of care, where they get follow-up weekly. They get a dedicated outreach worker who, if they don't show up for an appointment, will continue to reach out to them to get them re-engaged and bring them back in. And because of this, these approaches, the National Action Alliance for Suicide Prevention uses the CSSRS as a screening tool and safety plan writing, which was developed for the VA, as their sort of 1-2 punch for providing a safety net for people who might be suicidal. Now, the safety plan that the VA uses was written by Dr. Barbara Stanley and Dr. Greg Brown. That's the one that we recommend. If you Google Stanley and Brown safety plan, you'll find that VA safety plan. It's a fantastic tool that you can give somebody the first time you see them, so that if they have any issues until the next time they see them, they have a plan for what they can do. And the CSSRS is central now to the national strategy for suicide prevention, with a military-wide instruction for branches to use it. And in the VA system, this CSSRS was used in a study to identify suicide risk. So 8,000 veterans in the VA were screened in this one study. There were no suicides at all in those 8,000 during the 4 years of monitoring. 3 of them scored as high risk and needed to be hospitalized, but 46% had a lifetime behavior that put them on the radar. This was done at the Tennessee VA. And so, as you can imagine, because of this better screening instrument, it's having a strong impact on care delivery and service utilization. And that's because of these research-supported thresholds for next steps. And what those thresholds are a 4 or a 5 or a 6. So if there's a yes to question 4 or question 5 or question 6, you know you have to take immediate steps to provide safety. Question 4 and 5 are when they have intent to act on their thoughts. So the difference between 3 and 4 is 3 is where someone says, yeah, I've thought about using my firearm, but I would never do it because I have family that I love and care about, I have reasons to live. A 4 is where they start to say, I really thought that I was going to do it last week, or I have intent to do it in the coming weeks. It's that intent that makes risk super high. And then question 6 is if they've had a behavior over the past 3 months. Any behavior of those 4 behaviors within the past 3 months indicates high risk as well. And so I want to show you a short demonstration video that the Air Force chaplains made of a peer-to-peer implementation of the CSSRS. Okay, so we know that peer-to-peer is one of the best ways for us to implement these kinds of instruments because people will listen to their friends. People say also often to me, if we start screening everybody, aren't we going to have our hands full of people who need help? And in fact, the study after study has shown that it's about 1% to 2% of people who will show up as high risk. So this is from the Detroit VA. They said when we trained them, we're the VA, we have high-risk patients. We're not going to have 1% to 2%. We're going to have a line out the door. And so they looked at 3,000 of their vets who were seeing a psychiatrist who had a mental health issue, the highest risk of the highest risk. And what they found when they looked at those 3,000 vets is that 14 of them screened positive, so 47/100%, and only 5 on further evaluation needed to be hospitalized. But there were 5 people that they didn't know before needed to be hospitalized. And so it's helping reduce false positives via the PHA, the Periodic Health Assessment, in the National Guard now. So it's used in every soldier-to-soldier and leadership-to-soldier interaction. 3,000 screenings were completed in 2014 to 15, and they identified 11 soldiers who needed help. And when we just ask these kinds of questions, we break the silence and give permission to connect and build a path of openness and resiliency. It's being used now in Israel by every school teacher. And the suicide prevention director for the country of Israel says that this is not only saving millions of lives, it's literally changing the way we live our lives, breaking down the barriers that have been built up over thousands of years. But we're just one nation, and every nation deserves this life-saving tool. And this common language is an intervention in and of itself. Just hearing about these definitions actually helps you to prevent suicide. And building these buddy-to-buddy quick response support systems by teaching people to just ask is a life-saving intervention. It's a method with a message that fights the loneliness and the helplessness that causes suicide. So I will be here for the whole day, so feel free to write questions that you might have for me. If you want to send us an email, you can send it to Dr. Posner's email box. I read everything that comes into there and screen them for her, so I'll see your emails. And you can go to our website and you can download copies of the scales, you can download videos of webinar trainings, you can download all kinds of tools, the ACE cards that you can distribute in your community. We have ACE cards for teens to ask their friends, ACE cards for parents to ask their children. All of this is absolutely free, and we encourage you to go out there and to save some lives. So thank you very much for your time.